Hi, everyone, and welcome. Let me admit everyone. Um, my name is Dr. Arun Nagendra, and I'm the Scientific Director at the Schizophrenia and Psychosis Action Alliance. Thank you for joining us today. We are at a historic moment in the treatment of schizophrenia. On February 24th, the FDA announced that the elimination of the Clozapine risk evaluation and mitigation strategy, also known as the Clozapine REMS. They stated that the program is no longer necessary to ensure the benefits of clozapine, that the benefits of clozapine outweigh the risks. They also emphasized that removing the REMS will reduce the burden on the healthcare system and improve access to clozapine. Clozapine is the only medication currently approved for treatment-resistant schizophrenia. Yet for too long, the REMS program has not only been burdensome, it has actively harmed access to this life-changing treatment. The REMS was removed because of the collective and sustained advocacy of people with schizophrenia, their caregivers, providers, and others. The Schizophrenia and Psychosis Action Alliance is proud to have played a role in this milestone, which embodies our mission to remove the unnecessary barriers that stand between people with schizophrenia and the treatment that they need to recover. But removing the clozapine REMS in and of itself is not enough. We now face a new task. How can we equip providers with the tools that they need to prescribe clozapine appropriately and safely? That's what we'll explore today. With that, I'm delighted to introduce Jessica Markowitz, a clinical psychologist, one of S&P's scientific advisors, and our moderator for today.
Thanks, Dr. Nagendra, and thank you to everyone who is joining us today. Before we get started, I just want to remind everyone that the webinar is being recorded and we will make the video available afterwards. Many of you submitted questions when you registered, and we will address as many of these as we can today. If you do have additional questions during the webinar, please submit them directly to Dr. Nagendra using the chat feature in your Zoom. And with that, let's get started. Nicole, can you pull up the slides? Sorry, I don't see the slides. Are they up?
You don't, does anyone else see them? I have them up.
I can see the slides.
They're up.
Okay. Okay. I just can't see them for some reason. Okay, great. Glad that they're there. All right. So I want to briefly introduce our expert panel, Dr. Ray Love, Dr. Robert Cotes, Michael and Angela Brisbane, Dr. Deanna Kelly, and Dr. Rob Laitman will be sharing their perspectives and expertise with us. Our program today covers a range of topics, including a brief background on the REMS, the effort to eliminate it, and what has actually happened, what this means for people with schizophrenia and their families, information about blood testing considerations and recommendations, as well as the pharmacist's perspective, challenges, opportunities, and next steps for prescribers, and a practical approach to optimizing safe and effective use of clozapine from the perspective of a prescriber and family member. We will end the webinar with a panel discussion where we address some of the many questions that were submitted by you. The panelists have the following disclosures. And now I would like to introduce Dr. Ray Love, who will be telling us more about the history of the REMS and details about the changes that have been made. Dr. Love.
Thank you, Jessica. I'm a psychiatric pharmacist, and I've been working with clozapine since before the drug was released to the US market 35 years ago. Next slide, please. So the question I want to first answer is, how did we get here? For many years, clozapine was prescribed and dispensed through a collaboration between the prescriber, and the community pharmacist. And that system had worked well for a long time. Then in November of 2015, the FDA introduced the first REMS for clozapine. And psychiatric pharmacists and the American Psychiatric Association quickly objected to the REMS. We thought that it was complex, that it caused a lot of extra work for folks, and that it could actually prevent people from accessing clozapine. We asked the FDA to delay its implementation, and of course they didn't. And in the following years, we kind of learned to cope with it, a very few changes about it. Then in 2021 came the second REMS. And again, when we looked at the second REMS, it really repeated, compounded, and amplified the mistakes of the first REMS. So before it was ever implemented, we had about 8 stakeholder organizations that got together and asked the FDA to again delay the implementation and make major changes. Of course, the FDA again was unable to do that before the REMS was implemented. 2 days after it was implemented, we requested the FDA to hold an emergency meeting, and they suspended parts of the REM, what you may have heard called an enforcement discretion in FDA terms. And in the next couple of years, we had about 9 meetings with the FDAs and the pharmaceutical companies that make clozapine, trying to get changes, and only saw very small changes. Along the way, our coalition, our group of stakeholder organizations, grew substantially. S&PAA joined us in that effort. And in 2023, we recommended to Congressman Sherman that he request an advisory committee meeting with the FDA. Now, we'd been requesting this for several years, but Congressman Sherman was key in trying to get that meeting. He met with high-level officials in the FDA. The meeting came about, and as a result of that, we had the meeting that took place on November 19th of last year, and then that brought us to what happened at the end of February. Next slide. Just to show you some of the people that contributed to this effort, there were pharmacy organizations, nursing organizations, psychiatry organizations, advocacy organizations, even the association that represents the directors of mental health in each of the states and territories joined into this effort. Next slide, please. So at the November 19th meeting of the FDA joint advisory committees, there were 2 big questions that were asked. And those questions really were about the need for education and certification of prescribers and pharmacies, the need for documentation requirements, the needs for the pharmacy to get some sort of okay from the REMS before dispensing clozapine. And on all of these issues, the advisory committee voted and recommended that those things weren't necessary anymore. Next slide. After the advisory committee, did we skip one there? No, we're on the right slide, excuse me. After that committee, the stakeholders continued to work together and to try and decide what the next course of action would be. And of course, in February of 2025, the FDA announced its decisions. And those decisions had a couple of key points in them. The first is that after the decision to eliminate the REMS was announced, a lot of people were confused about what it meant. Many people thought that the announcement meant you didn't have to monitor blood work anymore. But in fact, the decision was that the FDA still recommends that prescribers monitor patients' ANC according to what's in the package insert. And even though the advisory committee said you didn't need to send those into the REMS, they agreed that we need to monitor patients' blood on a continuing basis. The FDA did acknowledge that eliminating the REMS would decrease the burden on healthcare delivery system and improve access to clozapine for patients. So that was a nice admission of the impact of that REMS and why they got rid of it. And finally, they said something which was not really clear in its meeting, that the FDA will work with the clozapine manufacturers to update the prescribing information. Well, on the surface, we think that means that they're just going to take the word REMS out of the product labeling, but it could mean that perhaps they might make other changes in the future. And certainly all of the groups we've been working with are pressing for other changes to that. Next slide. So what does all this mean? So what it means is that clozapine still requires blood monitoring, especially at the beginning of treatment. We do know that there's some scientific papers coming out which might recommend a different schedule, but monitoring will still be recommended. Prescribers and labs can forget about submitting the lab results to the clozapine REMS. Pharmacies shouldn't need an authorization from the clozapine REMS or lab data to fill a prescription. We're concerned though because payers and pharmacy benefit managers and some pharmacies may not have changed their procedures, so they still may require and put limitations in place. It doesn't mean that pharmacies are going to stock clozapine. We still need to work with pharmacies to get them to stock clozapine. And then in the past, people have been limited to very small supplies of clozapine. Those limits that were as a result of the REMS will disappear, but some of the payers may still have their own limits on how much clozapine a patient can get in a prescription. The other thing that's nice is pharmacies and prescribers don't need to get certified to be able to prescribe or dispense clozapine. In the old clozapine REMS, or in the clozapine REMS that we're just transforming from, it maintained historical information that was useful to prescribers. That information may disappear. We're trying to work with the manufacturers so it doesn't disappear, but it may disappear. So we're encouraging prescribers to go ahead and download that information now and put it in their patients' medical records. The bottom line is this is more of an administrative change about record keeping and workflow than it is a clinical change. So monitoring will still be required. It's just the process, for the most part, will change. With that, we'll go to the next slide and on to the next speaker. Thank you.
Thank you so much, Dr. Love. That was great and very informative. Next up are Michael and Angela Brisbane. Michael represented the lived experience perspective at the pivotal FDA advisory committee meeting, and Michael and Angela will be speaking about their lived experiences as a person with schizophrenia and their parent. So Michael and Angela, over to you.
Hello, everyone. My name is Michael, and I'm here today as a clozapine patient and advocate for people living with schizophrenia. I just wanted to talk about the importance of the patient voices and policy changes, the impact of clozapine REMS discontinuation, and what we need to do to protect ourselves moving forward. Due to the inability to think clearly and cognitive defects, many people with schizophrenia suffer in silence. We often feel unheard, especially when it becomes to decisions that affect our treatment. But changes like these, the discontinuation of the REMS program, directly impact us. This is why it's so important that patients have a seat at the table when decisions are made. Our voices matter. I know firsthand how difficult it can be to navigate medical treatment when struggling with a severe mental illness. Before Clozapine, I had trouble understanding my medical needs, and many of us in this community face the same challenges. But Clozapine changed that for me. It gave me clarity and the ability to advocate for myself. It gave me back my life. So that's why I'm here today, to make sure that others can access this life-changing medication safely and without barriers. In November, I was honored to be selected as the Clozapine advisory panelist for the REMS meeting. And I also lead a peer group where I help others understand their illnesses and know that they are not alone. So with the REMS being discontinued, things are changing. We have to be prepared. One of the biggest concerns is the loss of physician oversight. Many patients and caregivers relied on the structured system to ensure safety. But now it's time for us to be more aware of Clozapine's potential side effects. Side effects including neutropenia, when a dangerous drop in white blood cells, and this makes it harder to fight infections, constipation and bowel blockage, toxicity during infections, which can be life-threatening. But here's the good news. So with this change, many of us are now able to get a 90-day prescription for Clozapine instead of having to refill every 7 or 30 days. This means fewer pharmacy visits, more stability, there's less risk of missing doses due to prescription delays, and we now have the ability to travel without the stress of running out of medication. For those of us who depend on Clozapine, this increased flexibility can be life-changing. But now that with less structured monitoring, it's important that patients take the right steps to protect themselves. One thing you can do is to consider asking your doctor for a standing order for ANC, absolute neutrophil count, and Clozapine serum levels every 2 weeks or monthly. This way, if something feels off, you can get tested immediately, even if your doctor is available. Another major issue is hospital policies. Some hospitals and psych facilities may not be aware that REMS have been discontinued. They can prescribe Clozapine without requiring a lab test, but some may still refuse to due to outdated policies. This is why patients and caregivers should bring documentation and be ready to advocate for proper care. In the past, hospitals would often stop Clozapine completely because of during a psychiatric hospitalization because of the hassle of lab testing and REMS reporting. So we hope that that no longer happens. So in order to protect your right to treatment, I encourage everyone on Clozapine to have the legal documents on hand whenever you're going to go get your medicine, including a medical release form, and make sure your loved ones have a power of attorney. So the end of REMS doesn't mean the end of patient safety, but it does mean that as patients, we should take more responsibility for our own care. We should stay informed, advocate for ourselves and others, educate doctors and hospitals, and prepare legally to protect our access to treatment. Clozapine has given me my life back, and I want to make sure that everyone who needs it has the same opportunity. Thank you.
Hi, I'm Angela. I'm Michael's mom, and I'm here today as a caregiver and an advocate, and I'm also the administrator for Team Daniel on the Clozapine Community Facebook group. I want to talk about how the discontinuation of Clozapine REMS program is a step in the right direction and what we as caregivers and patients and advocates can do to support this positive change. For years, Clozapine has been overregulated due to the risk of neutropenia, which is a real risk, and even with the discontinuation of the REMS program, it's still important to make sure that you're getting that testing especially during the first 18 weeks of treatment when the risk is highest. But by ending the REMS, patients now have more freedom with fewer obstacles and better access to their medication. So the change means fewer medication disruptions, medication is easier to access, and there's more control over your treatment. Patients and caregivers can now work directly with their providers to make individual decisions about the monitoring. So while neutropenia is, hold on a second, I've lost my spot here, what I'm talking about. So I want to make sure that patients and caregivers educate themselves about the risk for neutropenia and that they know what the signs and symptoms are. And I'm sure that's going to be covered later by the doctors, but know that if there's a fever or infection, sore throat, mouth ulcers, unexplained weakness and fatigue, and maybe cuts or wounds that don't heal, these are all indications that your white blood cell count might be too low to fight off infections. And so when that happens, it's important that you ask for testing or that you go to the doctor and you mention that you're having these symptoms. And even though REMS has ended, not everybody knows about the changes yet. Some pharmacies and hospitals and even providers may still think that blood tests are required before dispensing clozapine. If you run into this issue, you need to make sure to educate them. Because providers may not be aware of the change, be prepared to show FDA updates. You can have the website pulled up on your phone, or you can print the update out and have it in your vehicle or in your car to take with you to the emergency room or the psychiatric facility or the pharmacy when you go to get prescriptions refilled. And then, as Michael mentioned, ask the doctor for a standing order for these lab tests. That way, if you can't reach the doctor, you have a standing order. That means it's like a lab order that's written out that's good for 6 months, that if you start having these signs and symptoms, you can go to the pharmacy and you can, or not the pharmacy, you can go to the lab and you can get your ANC levels checked to see if you have neutropenia. Also, it might be a challenge to find a clozapine prescriber. I know that with the ending of REMS, there probably will be more physicians that are willing to prescribe clozapine. So ways to find out if a prescriber's in your area is you could go to the Team Daniel and the Clozapine Community Facebook group, because we maintain a member-provided list of prescribers on that support group. It's located in the featured section and in the group files. So it's very large actually, and it's not just for the US. We also have a provider list for other countries too. You can go to the Cures map. So if you go to cures.org, it's another non-for-profit that advocates for clozapine use. They have a clozapine provider map and a list as well. You can call your local pharmacy and ask if they stock clozapine and which doctors prescribe it. You could also go to ProPublica's Medicare provider search to find doctors in your state who prescribe clozapine. And then lastly, you can call your state's mental health authority, and they usually will have a list of clozapine clinics in your state. So what do you do if the provider won't remove the restrictions, as far as they want to continue to basically do the enforcement just like REMS was doing? You can show them the official FDA documents confirming the REMS discontinuation, and you can always look for a second opinion as well for a doctor who understands the new guidelines. So our next steps in advocacy as patients and caregivers would be to, hopefully we're going to continue to change or to push for changes to the product label to maybe slow down the fast titrations that are currently happening, and management of side effects, more education as far as that's concerned. And I also advocate for at-home monitoring options such as the Athella's finger prick device. You could always use that if you have access to the device to find out even at home what the neutropenia count is. So an action plan is that since many providers still don't know that REMS is over and some hospitals may continue the outdated practices, I'm going to be preparing an educational document for caregivers and patients to carry with them. The document's going to include a summary of REMS discontinuation, so what patients and providers need to know, signs of neutropenia and when to seek medical help, how to continue blood monitoring without REMS, information for our pharmacists, how to find a clozapine prescriber, and the most common side effects of clozapine and how to manage them. If you go to the Team Daniel and the Clozapine Community Facebook group, this document's going to be available for download within the next couple days. So final thoughts are that now it's up to us as patients and caregivers and advocates to make sure that our providers and pharmacists understand the new changes, that patients get accurate information and the support that they need, and that we continue pushing for policies that protect access to clozapine without unnecessary restrictions. So with that, I thank you all, and I turn this back over to Jessica.
Thank you so much to both of you. And I just want to say, Angela, you gave some really great suggestions for finding clozapine providers, and we can include that in the materials that we post after the meeting. And also, I think we'll include a link to the education document that you're creating, because that seems like it will be an excellent resource. So thank you both very much. Next up, we have Dr. Deanna Kelly, who will be talking about a topic that I know a lot of you are very interested in, which is blood testing considerations and recommendations. And she will also be providing us with her perspective as a pharmacist.
Great, thank you so much. Go ahead and advance the slide here. So as Jessica mentioned, I have a couple of perspectives here. Many of you might know of me working from the research perspective and working for most of my career publishing papers in the area of breaking down barriers with clozapine. I'm going to talk a little bit about that, and specifically as it relates to monitoring and where we're moving with monitoring. I also, being a psychiatric pharmacist and in the field, I have some perspectives I'm going to add just to give us some open up dialogue to help us to think about that. So go ahead and keep moving on. We're going to be talking about some facts of agranulocytosis and severe neutropenia. You can go ahead and go to the next slide. I want to make sure that everyone is on the same page about what are our risks. Most of you are very familiar with how low the risk is of actually having severe neutropenia or agranulocytosis. But neutropenia may occur specifically in some of our patients who are African descent or our Black patients, and that is okay. And I want to make sure we understand that. So as to set the facts, the peak incidence of having severe neutropenia, this drop in the absolute neutrophil count that we've been talking about, happens generally between 4 weeks and 6 weeks. The period of highest risk is usually around that period, and it's highest then in the first 18 weeks. And that's why all guidelines suggest that we monitor weekly for the first 18 weeks. And that's what our package labeling says in the United States as well. The risk of having this happen is less than 1%, arguably less than 0.6%. So giving you a context, there is data that suggests that it's only in about 0.3 to 0.4% as well. But again, all under 1% will have severe neutropenia. There are a few cases that have happened beyond 6 months, but these rates of severe neutropenia do decline to being negligible after 1 year. Cases that happen after 1 year or 2 years, and there are people that have reported these cases, may or may not be related to clozapine. And so we believe that potentially these are due to idiosyncratic, or meaning other things going on in people's lives. But keep in mind, the first 18 weeks is the period of biggest risk. There is potentially some genetic information that helps possibly guide us at who might not be at risk or who possibly could be at risk. There is genetic testing that helps guide that. The myogenes, for example, is something that's been used in Europe, coming possibly under study in the United States. But it's not specific to tell us who will be at risk, but it helps guide us. So we will have guidance coming that will help us understand who may be at more risk or less risk with having agranulocytosis. But deaths from agranulocytosis or severe neutropenia are extremely rare. We're talking 1 in 7,500, 1 in 10,000-ish of this. But neutropenia itself, let me move on here. Advance the slide, please, sorry. Neutropenia itself is what we call in the white blood, the absolute neutrophil count under 1,500 or lower. This does happen with people, and that it has in the past put us into more frequent monitoring. But what we need to know is that some groups of people are at a normal risk of having this happen as part of their genetic makeup. So particularly this happens from people who are African American, African descent, or Middle Eastern. It's not the same as agranulocytosis. If someone has a low white blood cell count and they come up and down, they're a little bit lower than the 1500, that does not mean that in all cases they will progress to having agranulocytosis. About 4% of people treated with clozapine will have neutropenia at some point in time. And there is some data suggesting that neutropenia, an absolute neutrophil count less than 1500 is not different. The rate of that or the risk of that is not different than other antipsychotics. So it's separate from the severe neutropenia that we all worry about where monitoring is in place for. We do know that Black patients have a lower ANC overall. It's normal, and we have to normalize that. So there is a genetic polymorphism, meaning the specific genetic type that puts people at the risk of having this low white blood cell count all the time, meaning risk that they have the propensity, not a risk of anything significant. You can move the slide. This is just one piece of data here, what I'm showing you on the next slide, from some of our work that was published last year. This is a large study that's all Black patients across the globe in Maryland, DC, in Nigeria, for example. We treated 274 people with clozapine and did their genetics on this one gene called the dark gene or the ACR1 gene. And we looked at the genotypes so they could either have C alleles or T alleles or have a mix of the C and T. That's the sort of the genetic polymorphism that shows up when you do the test. And you can see here the split. If you have the green line, for example, shows that you have a T allele as part of your genetic composition, and your white blood cell count or your absolute neutrophil count will run higher. But if you happen to have the 2C alleles, and this is a Black population again, you will have a normal lower white blood or absolute neutrophil count. And you can see the bottom line shows you, and the difference is quite profound. It's about 1500 difference. So neutropenia could happen more frequently because people can dip down. So I just want to set the stage that neutropenia is not the same as severe neutropenia or agran, and that people normally can dip down into the neutropenia range, specifically and more commonly in those who are Black. You can advance the slide. We also showed that in our large study of 274 people, we only had one case of severe neutropenia happening in someone who had it before. So the risk again that we saw was 0.36%. So as Dr. Love pointed out earlier, we still are in a situation where we are following the package labeling for monitoring. This is our gold standard. This is how we understand it as a field and as the U.S. of monitoring in the package labeling to date. I'll also talk about how it's emerging and how other countries are changing and how we might see changes in this happening. But just to point out right now that the weekly blood draws for the first 6 months, as I've pointed out, across the globe, no one argues with the fact that the first 18 weeks should be weekly to the best of our ability. Now, of course, people, if they missed or they were sick or we now have some more leeway there. We certainly do, but we should be monitoring for the first 18 weeks. Right now, the package labeling and our labeling in the US suggests that we should do every other week for the months from 6 to 12, and then monthly blood draws after 12 months. And I'll talk about then how these are changing in other countries and how we might in the future have some of these changes made. If we as a collective community, as a global and US community, set the stage on the research agenda that this is our new standard of care, this could then move the FDA to potentially changing labeling on the monitoring. And that's what we all hope to continue to work in. So go ahead and move the slide. Give you an example. In Chile, for example, guidelines came into place in 2022 as some other countries had opted to change to less stringent monitoring as well. In Chile, for example, it's weekly ANC for the first 18 weeks, every 4 weeks. After that, up to a year. And then in this instance, it becomes every 8 weeks after the first year. So every other month in this country of Chile. As an example, you can switch to the next slide. Some of you might also be aware of the new European Clozapine Task Force proposal guidelines that came out just in January of this year. And these were the European guidelines suggesting as a consortium across all of Europe, what should we change to? What are current and what are our proposed guidelines? And what I want you to pay attention to is that the suggested monitoring guidelines for the European from the European group suggest that, again, weekly for the first 18 weeks, as all guidelines state, and then monthly up until the 1 year period, similar to what we see in Chile. But again, remember, we're every other week in the United States right now. But after 12 months, moving to 12 weeks if there's no history of neutropenia, and then after 24 months, moving this to yearly, as the risk goes way down, as I had pointed out. So after a couple of years, this is where the consensus is starting to grow that we should have much less monitoring after this period of time. You can move on to the next slide. Additionally, we have a group that's been meeting internationally. This is not published or put out in the public domain yet. I'm an author, a co-author on and part of this project. It's called the Delphi Consensus Recommendations. These are when international experts get together and publish and put together guidance on minimum of what people can agree upon. Now, mind you, this is over 90 people coming together. So there's a few very high level recommendations that come out of these type of guidelines. These are going to be presented at the Schizophrenia International Research Society meeting at the end of the month here. And they're going to be in press. But I wanted you to know that there'll be recommendations that for the first 18 weeks, monitoring occurs, and then after that, weekly, or for monthly after that until 2 years will be these recommendations that'll come out for these Delphi consensus guidelines. Move on to the next slide, please. I'm just about out of time. I wanted to keep going there, please. Keep going. I wanted just to give you a perspective from the pharmacy aspect real quick. The pharmacist as overall is part of the healthcare team. In many situations, I'm a psychiatric pharmacist and we exist in healthcare systems where we all work together as a team. And that the American Association of Psychiatric Pharmacists has been advocating with SNPAA and others right along the way. So I wanted you to know we're part of the team. We've been involved with this, but move on to the next slide, please. But largely the community pharmacists at large are going to have a lot of education. Those out dispensing are going to need to know what the changes are. And as Michael and as Angela pointed out, we might have to do some advocating at that level. At the high level, we are working with the organizations, all of us, to help understand the pharmacy benefits organizations, management organizations, the pharmacy chains to help them know. But we want to move this delay that's been happening at the pharmacy. As you all know, there was reports at the FDA advisory panel that 7 days was sometimes happening in people. Go ahead and move to next slide. We want to avoid that 7-day period of time, and we want to have everybody getting their medication the first time that they're in. You can go ahead and move on. And again, please. As I was saying, we have this top-down and bottom-up education approach that we need to do, but advocating as individuals, it's important because there's going to be a little bit of chaos in the short term, but we need to do a good job of breaking down all barriers to the dispensing level. You can go ahead and finish up, please. Next slide. I just want to point out as we move into the next talks that this is work that's in press right now in SCIS Bulletin from some of our research. This is from the state of Maryland and almost 300 prescribers. But these are how people relate to be their most challenging barriers to prescribing clozapine from the last couple of years. And across the board, there's a lot of barriers. The clozapine REMS was reported about 24% of the time to be one of the most significant barriers, which is significant, but it's not the only barrier. We have lots of work to do on educating our prescribers about use around side effects, et cetera. And we're going to touch upon, Dr. Lakeman and Dr. Cotes will touch upon those. But I wanted to point that out, that this is our chance now to overcome one of the significant barriers that we have. Thank you so much.
Thank you so much. That was great. Next, I would like to introduce Dr. Cotes, who was involved in the FDA Advisory Committee meeting. He will be speaking about his perspective as a prescriber and specifically the information that prescribers should be considering at this point in time. Dr. Cotes.
Thanks so much, Jessica. I wanted to add some thoughts from the prescriber perspective. I work at Grady Hospital in Atlanta, Georgia, and there I was inpatient medical director for many years and developed a Clozapine clinic in 2012. So can offer some thoughts from kind of the inpatient and the outpatient perspective. I just wanted to also mention that, together the stakeholder group has made a significant amount of progress. And I also want to remind everyone everyone kind of in the system to give everyone some grace as this transition occurs. Next slide, please. All right, so the first thing I want to do is address the green box on this slide. And one of the most important points here is, as per the FDA announcement, ANC monitoring as per the package insert is still recommended. Okay, so I think that the change here offers a number of opportunities and it offers a number of potential challenges, which I'm going to talk a little bit about. And the biggest upside here is the potential for fewer interruptions in Clozapine access. And I think that we saw so many times in the advisory committee the devastating consequences of people missing Clozapine doses, and some of the time, folks just couldn't even get their lives back. So I think that this is really one of the key things. Another important implication here is that there's going to be greater flexibility in certain prescribing and in certain monitoring situations. First, though, there is likely going to be greater discretion in dispensing Clozapine despite missing ANC. And it's interesting because this flexibility actually did occur in the previous REMS, and you had an option as a prescriber to say, the patient refused labs or there's extrinsic factors that made it impossible to get to ANC. But the problem was that sometimes at the pharmacy, you had to present the ANC itself in addition to the REMS. So now there's going to be some additional flexibility. And if you look at some of the research that was in the FDA briefing document in the advisory committee, monitoring wasn't perfect before, even despite having a REMS system. And one of the key takeaways from one of those studies was that, I don't know what 20% of people this were, but 20% of people actually never had any monitoring in the system and might have been getting Clozapine in the enforcement discretion. Okay, so another, I think, opportunity here is that new Clozapine starts may be possible with an extensive risk-benefit discussion when initial monitoring is challenged. It's sort of a future implication that we heard that really it's those first 18 weeks that are going to be the most important to be doing monitoring. Okay, I really like what Michael had said earlier, and that as a patient, it's so important to think about what level of risk do you feel comfortable with? Does your family feel comfortable with? Ken Duckworth at the advisory committee meeting talked about the dignity of risk and really kind of thinking through what the risks are. Before, with the REMS system, the risk was sort of decided in this sort of external thing. But now it's really going to be a shared decision-making conversation with the prescriber and with the patient and other people that are involved. And that's going to be a big change. And I think that there is definitely some dignity in risk. And in at least choosing the risk that at least dignity in choosing the risk. Okay, next slide. So after the FDA decision was announced, the first question people asked me, at least, was, so what's going to be your monitoring frequency? And I said that, well, I don't really think it's going to be, I don't think it's going to change all that much, at least right now. But we asked, we surveyed a number of psychiatrists and pharmacists through SMI Advisor 2 years ago, and we asked them, if there was no REMS, what would be your strategies for monitoring the ANC? This was a group that was very experienced with Clozapine, and many of them actually had seen a case with severe neutropenia in the past. And then, what we found was that 96% said they would continue monitoring as per the package insert for the first 6 months after Clozapine was initiated. Then there was a variety of responses about doing spot checks at 6 months, at 12 months, or at 18 months. Next slide. So another big opportunity is the quantity limits here, which I think that the narrow supply of clozapine often caused many problems and led to a lot of anxiety each month about making sure that one could get their medication. I think that there's nice implications for the inpatient unit, for example. So now, even in early, potentially when people are getting started on clozapine, an inpatient could be discharged 30-day supply, making transitions easier. And this gives people more time to get connected to a clozapine clinic after after they're started on clozapine. Michael also talked about the increased flexibility with a 3-month supply potentially that might allow travel for people. And I've had patients who have had their trips canceled because we couldn't dispense more than a month, particularly in international travel. Okay. Another thing that is really promising is the potential for greater pharmacy stocking without certification barriers. And I work at a hospital that has a lot of different pharmacies, but only certain pharmacies had a pharmacist that was REMS certified. And now we're going to be able to give patients clozapine after they're discharged from the hospital without having to walk to a separate pharmacy and picking up the clozapine over there. I think overall, this allows us to kind of rethink about some of our monitoring perspectives, and we can really think about more holistic monitoring for things like clozapine-induced gastrointestinal hypomotility, myocarditis, and think about it in a really more holistic way. Will this result in less prescriber hesitation? I hope so. Next slide. Okay, so a couple of next steps. We don't know how much longer the REMS website is going to be up, so it's important to try to download historical ANC results before access ends. I think, systems are going to have to revise their protocols, and instead of the REMS keeping track of the monitoring cadence, the prescriber is going to need to do that. How is outreach going to happen to people, for people, if the pharmacy was doing it before? I think that there needs to be clear language around the risk benefit of off-label monitoring. And we talked about some ways where you could find a clozapine prescriber. And one of the things that could have been, I think, quite useful was using the REMS data itself to be a prescriber locator tool, but now that's not going to be an option. I really talk to my patients about if you have a fever, it's kind of counterintuitive, but you don't call your primary care doctor, you call your psychiatrist. Understanding like what is that feedback loop that you have with your prescriber to talk about this sort of thing. I think a standing order is a great idea. I think there's going to be research that's going to take place to help us understand about the will this actually increase clozapine use or not, and then finally the REMS actually did have very good information about what to do when someone developed neutropenia, how to change the monitoring cadence to ensure safety. And we're going to have to make sure that that information remains and that there's some additional high quality training and resources. Dr. Laitman is going to talk about one approach to clozapine titration, which I think could be quite useful. Next slide. All right, I think I had one other slide. Can you go back 2 slides, maybe? Okay, yeah, so I'm going to just wrap up in a second here, but one of the big challenges is that, there's a concern that without a REMS in place, systems are going to set up their own sort of quasi-REMS approaches. And there could be variability in this, and it could cause a lot of confusion. So we're really encouraging people not to create their own systems that could potentially limit access. And then I think the other consideration is with, sort of the pharmacists out of the system a little bit in terms of the needing to verify the ANC before the medication is dispensed. There is a concern that the risk may shift slightly over to prescribers more, and sort of coupled with a lack of structure. I worry a little bit about this increasing prescriber hesitancy for some. So I think that, this educational effort is really, really going to be important as we move forward. All right. And with that, I'll turn it over to Jessica, and then she will introduce Rob Laitman.
Great. Thank you so much, Rob. All right. Next, we have Dr. Rob Laitman, who is on the board of SNPAA and will be telling us about a practical approach for the use of clozapine from his perspective as a prescriber, as well as a family member of someone with schizophrenia. Dr. Laitman?
Thank you. Thank you for all the speakers beforehand. So closing this out, I do think that there actually is a optimal treatment approach for clozapine in treatment-resistant schizophrenia and really other related psychotic disorders, especially when there's a co-occurring persistent suicidality. And next slide, please. And there you go. There's a general approach, and I term this called the EASE method, and it is just an approach. And basically in this setting, because we know that clozapine is the most effective, in fact, the only truly effective agent with true resistant psychosis, we want to use it as early as possible. And using something as early as possible in a illness as devastating as these psychotic disorders is critically important. To borrow from Henry Nasrallah, untreated or poorly treated psychosis like a slow-moving stroke where you're losing about 1% of your brain. So E stands for early use of the most effective agent, which is clozapine. A stands for really assertive monitoring. Yes, and we will be continuing to monitoring the ANC. It is important in the first 18 weeks. Again, though that risk is still very low, 99.4%, and should not be an obstacle if monitoring is not available. But as Dr. Cotes and others have pointed out, you really do have to do a good education. What I'm hoping as we educate our psychiatric community better is the benefit and risk ratio, where someone is persistently suicidal or in the jail and is violent, where that person has entirely incapacitated. Is it worthwhile starting someone on clozapine knowing that you can't, at first at least, use the appropriate monitoring? That's an open question. But really going after the predictable side effects is important, and that's where monitoring becomes very, very important, and also knowing where you are with the levels. Finally, as Rob just mentioned, slow titration. I think that's going to be something that people are have started to consider. There's mounting evidence for that. And then finally, an engagement, of the patient and the family, because you guys are the bedrock. You cannot do clozapine unless the patient and family is engaged. You really can't. You can't have someone coming on and off the medicine. Next slide, please. So early intervention, what are the guidelines right now? So the APA this is as fast as you should be getting onto clozapine. 2 failed antipsychotics, only 2 to 4 weeks, adequate levels, making sure that, the patient is taking it. Again, this is in someone with also with persistent risk of suicide or aggressive behavior. The treatment resistance response in psychosis working group consensus guidelines are, again, 6 weeks. Doses up to 600 milligrams of chlorpromazine. That would be about 300 in clozapine equivalents, with, again, a documented 80% adherence. You should be moving on to clozapine. Clozapine, again, for treatment resistance, even after 1 failed antipsychotic, the response rates in the literature are routinely well less than 5%, with 1 study showing olanzapine only at 7%. So the nonsense where it's 4 to 10 years before you're getting to clozapine, that shouldn't be, because delays are critical. And this is a small study, but it's often quoted out of Japan, which, by the way, has the lowest clozapine use in the world, even below the United States, which is second to last in the civilized, developed world. 2.8 years is a predictor of not having as dramatic a response. Having said that, it doesn't mean that you shouldn't be using clozapine. It means just things are going to be slower. And then where we almost never see clozapine used is that first year. And that is such a year. That year is so fraught in that the mortality rate for someone with a persistent psychotic disorder is 50 times that of the general population. And clozapine use here can reduce the risk by as much as 80 to 90%. Finally, in Finland, which has a national database where they look at all of their patients and they can really follow things, looking at the first episode psychosis, when they did that, what they found is that if after that first episode you switch to clozapine, you can lower the relapse rates by 34%. Interestingly, in this first episode psychosis group, they had 45% that were on no antipsychotic. So in that group, if you went right to clozapine, it almost lowered the risk by 50%. And switching to non-clozapine antipsychotics did not lower the risk of another relapse. And more importantly, even now, is switching off of clozapine doubled your risk. Next slide, please. Next slide, Nicole. Thank you. So assertive monitoring, go back to A, or EASE, really is important. First, you want to make sure that they're taking their slide. Anosognosia, we can almost put that in the A. The unawareness of illness, it's important that your person is taking the drug. It doesn't work unless you're getting it in. And there is truly a dose response curve. Unfortunately, as you go up on the dose, there's also a side effect dose curve that gets worse as you go. People always talk about the 350 nanograms per mil as the range, and often it'll be listed in your labs as 350 to 600. But we know that in a certain subset of this population, they need higher doses. And you see increased responses up to levels of around 1,000 nanogram per mil. Now, the other thing about management is actually doing rational polypharmacy. And I'm not talking about polypharmacy with antipsychotics. I'm talking about doing the medicine, because you can manage all the side effects almost. Constipation's predictable, weight gain's predictable, unless you add things such as metformin, now the GLP-1s, excessive siluria, which is excessive salivation, is physiologically to be expected with clozapine. So you need to treat these things. The fast heart rate as your levels go up also are a concern and can be treated. What almost stopped clozapine from being developed is at the very beginning, especially with fast titrations, there was prominent hypotension. In other words, your blood pressure fell and people would pass out. Again, entirely preventable. Seizure risk as well, especially when you're going to the higher levels. Clozapine lowers the seizure threshold. There is no easy way to use clozapine. It's just so much more effective. And that's why you go through the trouble, because you can restore your lives. And then finally, when they get well enough, that's when you get them into the wraparound services, because it's not just giving a medicine. It's doing psychosis-informed cognitive behavioral therapy, cognitive enhancement treatment, socialization, even befriending. We bring our kids to the house. It helps. Exercise, all important. Next slide, please. Nicole, thank you. Finally, slow careful titration. Slow stands not only for how you're using the antipsychotic, but slow is you have to be patient. This may take time. But the kicker here is, and where I see frequent mistakes made by other psychiatrists, is they will stop the other antipsychotic before even starting the clozapine. It is much better to go slowly and initiate the clozapine in the setting of the other antipsychotic, doing a cross titration. Again, it dramatically improves the side effects. So you'll find discontinuation rates, which are routinely, if you look at some studies, over 50% to less than 10%. It also limits the risk for myocarditis and neutropenia. In Australia, they tend to go too quickly. They have the highest myocarditis rate. In the Norwegian countries, they go very slowly and a very low myocarditis risk. Also, going slowly allows you to get to the optimal levels without a dramatic overshoot. We start at 12.5 at bedtime and go up 12.5 every 3 days. Next slide, please. Thank you. Engagement. That's, again, it has to be either voluntary or involuntary. Again, anosognosia, the unawareness of the illness, often necessitates using court-mandated treatment, but it's critical that you get the person engaged. The family needs to be involved when there is family. If there's no family, you've got to create a family. That's where sort of community treatment is, where the ACT teams come into play. Don't let HIPAA be an interference. Again, community, we have Team Daniel in-person gatherings in a non-medical setting. I really believe in this. We have weekly Zoom sessions for both patients and family. We encourage involvement in the NAMI. Next slide, please. So, I'm president of Team Daniel. I've had this charity named after my son who developed schizophrenia 20 years ago. I've been involved in this community now for 20 years. I made a 30-year deal. I want psychiatry to change the treatment paradigm for the treatment of psychosis. I want the nihilism to stop. I want them to understand that the amount of recovery that you can get is substantial. So we use clozapine first. That's my belief. Clozapine is not a drug of last resort. It is the gold standard. And again, we have the right to be well. So we use Javier Amador's approach: listen, empathize, agree, and partner. And if needed, we use court-mandated treatment. But we do not tolerate side effects. We're aggressive. We use the adjunctive medicines. We use the ultra-slow titration, diet, and exercise. And again, our goal is meaningful recovery. And we want to get our patients and family members back to where they were at their pre-illness baseline level of function and well-being. And we do fairly well in that. But more, almost critically, we really promote a sense of community and engage and communicate on a regular basis with not only our patients, but their family. And the thing that we've really found is that learned helplessness and hopelessness, we can get rid of that, and basically we can restore optimism. Thank you, Jess. I'm done.
Thank you so much. Perfect timing. Great. So we are going to move on to our panel discussion now. If all of the panelists could please turn your videos on, that would be great. Okay, great. All right. So to start, I'd like to start with you, Michael and Angela. Your talks were so informative and interesting, and I really appreciated all of the tips that you gave for other patients and family members that might be looking for providers and looking for support. Michael, could you speak a little bit about what tools or approaches you used to be adherent with blood testing and become successfully treated?
Adherence to blood testing. Well, I mean, I wanted to get better. I knew that if I didn't do the test and I didn't do the blood testing, that I would never get better. And so that was the main driving factor behind that.
Mm-hmm.
My mom helped too. She
Yeah.
made sure that I felt comfortable with it, and she explained to me what the process was and what it looked like to take this medication, the side effects that I'd have, and so those two things were big factors for me.
Mm-hmm. Great. Thank you so much. And Angela,
could add
follow
to
up on that.
Yeah.
Oh, sorry, go ahead.
Well, I was going to say, of course, during the beginning phases of his treatment, he didn't recognize that he was ill. It seems that almost all the patients have anosognosia, the inability to recognize their illness at the beginning. So things that I did to make it easier was I went and I scoped out different labs. I purposely chose a lab that was not as busy, that like we drove 45 minutes to go to a lab that was at a mental health clinic that Michael wasn't even a patient of, so that we didn't have questions from the phlebotomist of an attitude about why, as his mom, I was going in with him. Because we had done a few labs and at just Quest in a busy part of town that would just have one person after another, and the phlebotomist would give me a little bit of condescending attitude and didn't understand, or Michael was in psychosis, so he might act inappropriately or say things that didn't make sense, and they really didn't have the education to understand what was going on. So I chose a lab on purpose that was somewhere where people were very familiar with psychosis. The other thing that I did is that I chose a pharmacy that was at a mental health clinic that had these prescriptions on hand. And they weren't, a little tiny pharmacy in my hometown that doesn't carry antipsychotics and didn't understand the risks or the side effects. So we did those two things. And then I also made sure that his visits to the lab were an enjoyable, as good as I could, an enjoyable experience. I would reward him by going out for Starbucks, or we would, at the beginning he couldn't even go into restaurants because he was so symptomatic, but he could. We could go through a drive-through and I'd let him pick something, really great for lunch afterwards. But I made the whole day enjoyable. So even though these tests, maybe the doctors may not require them on a regular basis, they are still going to have to be done at some point or another. And as a caregiver, you just have to make sure that you do everything you can to make sure that it's not a miserable experience, and that your loved one actually starts to look forward to that little outing that they get to do.
Yeah, I love that suggestion. Thank you. And that's actually what I was going to ask you, just to give your perspective on that. So thank you so much. That's great. Following up on the blood draw recommendations, so we had so many questions about this prior to the webinar, and Dr. Kelly, you talked about blood draw recommendations in your talk. Can you discuss a little bit more about how you think these requirements sort of will and should work going forward?
Yeah, first I'll say that, absolutely, we want to be having the best risk to benefit ratio. So the least amount of monitoring for the best appropriate care is what I think we all agree with. And so I think one of the first steps is that there are new international guidelines coming out. There is a large infrastructure here, many of the people at this call who really care about this and are really trying to put forth sort of best modeling, because our labeling in the US still states that we have 18 weeks and then every other, and then monthly after that, even though it's different in other countries, which means that puts all of our prescribing off label if we do something different. And we would like to change that. And I'll talk about like what I think, like some of the things might be helpful, but currently, if you are going to prescribe off label for a variety of reasons, Dr. Love kind of pointed it out, Dr. Cotes pointed it out, prescribers should probably try to work that out, have that discussion with the family, have that sit down and talk about that. And then you do some documentation, because it still does put us out. We'd like to have best practices be reflected in the label, and hopefully that will come, but that's going to take some time. So we all agree. We all think that should move forward. We are limited by knowing that this is off label still, and that has to be documented and well taken care of. I do think that we're not going to change the idea of the first 18 weeks. The first 18 weeks, we all agree, I think, is a critical period that should be monitoring weekly. And all guidelines across the globe suggest that should be. Now, there's instances where people can't do that, and then you can be off label, et cetera. And those will be in important discussions, and that gives people the leeway to do that in situations where they can't. I know if we have a patient who has COVID for the week and we can't see them, we'll go out, we won't do it for that week. Now, currently we document, but now it's going to be a little easier to do those kind of things. I do think that it makes sense as the guidelines progress as a field, that after the first 18 weeks, there should be some lax on that. Now, we don't have agreement on what that could be as a field. You saw that in Chile, after a year, it's then every 8 weeks. And you saw that European guidelines say every 12 weeks. And you see that the International Consortium for Delphi are still going to be monthly until the second year. So there's not a consensus forming exactly. But I think one thing we will probably all agree on is after 2 years, that, you know, the risk is so low. We're probably going to be in a situation where we're saying, let's do it annually, or let's do it for every 3 months or something like that. But that period after the year, what's going to happen there? I can't say for sure what that should be. I have opinions, but I have thoughts, but I don't want that to guide specifically how that runs. But I do think that after the first year, we can start to be lax on that, meaning as guidelines come, as a field, we come together with less stringent and less frequent monitoring. But the bottom line is it's off-label still if we do it. We document that, but you can have those conversations. That allows us. 18 weeks is still going to be critical. But after that, we're going to start to see, stay tuned for what the next couple of years will look like, because hopefully we'll be able to make changes, and hopefully the label could change. But the FDA has not stated that they will be changing that yet in the label. So just so people know that. But if anyone else wants to chime in, I just wanted to state like some of those parameters around that.
Yeah, that's great. Thank you. Dr. Laitman, did you have anything to add on that? And you're on mute.
Right, unmute myself. Okay, good. Yeah, just like Deanna said, again, the first 18 weeks are critical, but I will reiterate, what is our biggest provider of mental health care? Where are our patients right now? They're incarcerated, and many of these people are suffering and are in danger to themselves. You hear a different story every single day. I'm going to actually be talking to New York State. I was invited as their speaker at their conference on moving forward in terms of what you can do with this psychiatric patient. And they have not used clozapine at all in New York State jails because of the required blood draws. So that's a situation where I think you're going to talk about the benefits and risks. You're going to have to talk to the family members. You're going to have to present things. Because the reality is the risk, especially in someone that you have in front of you, if they develop sores in their mouth, they develop a fever, which would indicate a low white count, versus potentially giving these people back their lives. I think that's a discussion worth having. You have someone whose life has been taken away, and you're limiting him not to have that for a potential risk of, remember, you're going to be successful 99.5% of the time. And I'm not telling you not to monitor if it's available. And hopefully as they get better, they will allow you. But, we should not be stopping people from getting the clozapine. And I would also say that even as an outpatient, when you know that this person is just in a position where it is poorly treated psychosis, they are not getting better, their brain is getting worse, their recovery is being diminished. Again, but you have to have the discussion. I agree with Rob. I agree with Deanna. I agree with Ray. You have to document, but in my hands as a clinician, whenever I've done any of these things, again, I come from internal medicine. I come from nephrology. We would, one of the things we learned when I was taking care of all my lupus patients is that if you were not aggressive with the disease management early on, you were dooming this person.
Yeah,
so
great.
I think it's the same setting here.
Great. And Dr. Love, did you want to add something?
Yeah. This really is a cost-benefit question for a lot of patients, as several people have pointed out. But the problem was when there was a REMS, it wasn't just between the patient and the patient's family and the prescriber anymore. And in Maryland, even prior to the first REMS, we had patients that we wanted to violate what was in the package insert. Frequently, they were patients with benign neutropenia. And we wanted to maintain patients on clozapine who had very low white blood cell counts, or who might be on cancer chemotherapy. And we were perplexed as to how to proceed, and we went to get legal counsel from the state attorney general. And they said, well, let's figure out a way to do this where you have consent and where the family and the patient and the prescriber and the facility, because we were talking about hospitalized patients mainly at that point, and everybody sat down and agreed that this was the right thing to do. But then we had to go to the manufacturer or later on to the REMS and say, look, we're going to do something that's outside of your guidelines, and we've got all these people signing off. The nice thing about the REMS being eliminated is now you don't have to do that, but you can still sit down and work out an agreement as to how everybody agrees that there's some risk involved, but maybe we can waive that risk in certain circumstances if we don't do exactly what's in the package insert. Not that we shouldn't strive to do what's in the package insert, but that there's a way out. And then the other thing that I want to mention again is if the fact that it's a venipuncture is a problem, I think several people have already mentioned the Athelis device and the fact that you can do a finger stick instead. That's another alternative. We realize it's expensive. It may not be available everywhere, but there are alternative approaches. But it's got to be a thoughtful decision as opposed to no, you don't need to get your blood drawn anymore. So it involves exactly what Dr. Laitman was talking about. Everybody coming together, having a discussion, empowering the patient, but making sure that all the bases are covered.
Yeah, great. We're going to switch. Oh, yes. Yep. Dr. Cortez.
I just wanted to add one quick point, and that, when you're having a discussion with your prescriber about monitoring frequency and things like that, I would argue that, if you've been on clozapine for a while, like the ANC is probably not the most consequential value of a laboratory to get. Like there's other labs that are extremely important that you want to make sure that you continue to advocate for and make sure that they're not missed. Like for example, we know that people on antipsychotics often are not in compliance with the APA/ADA guidelines on monitoring for cardiometabolic dysfunction. So people don't get hemoglobin A1C, lipid panels enough. We have to make sure that we're continuing to monitor those things. The other thing is therapeutic drug monitoring and clozapine levels. And if you have, I have, per the USPI, monitoring people indefinitely, monthly, and we get a level often because people have a complicated regimen. And I would say that, 9 out of 10 times the most there's actually a decision that can be made with the level, the therapeutic drug monitoring level, the clozapine level, rather than the ANC. So the level is very, very important to inform clinical decision making in some situations. So I think when we're thinking about monitoring, one temptation I would encourage people to resist is just because we're not monitoring the ANC, we're still monitoring other things, and that blood work is going to be, it's going to be necessary and important.
Yeah, that's a great point. Thank you. And I want to just sort of switch topics a little bit here, but actually continue with you, Dr. Cortez. And we had a lot of questions about prescribing patterns and access. And in your talk, you discussed opportunities for potentially receiving 30 or 90-day supplies and potentially easier access to extra doses. And I'm wondering if you could discuss that a little bit more and maybe talk about what needs to happen for these changes to go into effect.
Yeah. Well, to me, this is one of the biggest advantages of not having the REM system, is not having the dispense quantity tied to the monitoring frequency. It really does allow for a lot more flexibility, I think, for new clozapine starts and also for people who have been on clozapine for a long time. I don't know if all that much actually needs to change in order for this to happen. Right now, it's sort of a discussion with the insurance company and with the pharmacy about how much drug will they dispense. I think there may be some chain pharmacies whose policies and procedures haven't been updated. Maybe there's some holdups with the PBMs around if this can actually happen or not. But I do think that some pharmacies may be able to dispense, 3 months if the insurance will pay for it. And I also think that in the beginning, when people are started on clozapine, a 7-day supply can be a really, really difficult thing to deal with. Like your margin for error is zero, like you have to get the blood work on day 5 or on day 4 or whatever, just to make sure that you get things going. And I think as a lot of people on this call, like I really encourage people to do a slow titration. And sometimes when you're starting somebody on clozapine, it does make sense to give a short supply because you're going to be increasing the dose. But you can actually build some of that flexibility. You can predict some of that a little bit, and you can give people access to a little bit more clozapine. The other thing that I think is important here is that if somebody does develop neutropenia, people can have extra doses of the medication. You can tell them to stop the medication. You don't have to, I don't think it's a worry that somebody has like a couple extra doses and they develop severe neutropenia. We have enough respect for our patients to say that they can stop the medication and we don't have to worry about them having a couple extra pills around. We want them to have extra medication.
Yeah, great. Thank you. Another question that people were wondering is, with the removal of the REMS, will more clinicians decide to prescribe clozapine? And of sort of a follow-up is any doctor allowed to prescribe or other clinicians? Dr. Love, do you want to take this one?
Yeah, I think that everybody on this call knows that the REMS was eliminated, but there's a lot of people that don't know that the REMS was eliminated, and don't know what it means in terms of things like days supply, or how am I now going to track things, or where's the information on the patient previously, or how many antipsychotic trials have they had, or whatever the issue is. And one of the things that group of stakeholder organizations that we've talked about is trying to do is work with the FDA and work with the manufacturers to get education out. And we want to be able to educate prescribers about all the things that Dr. Laitman and Dr. Kelly and Dr. Cotes have talked about, because people still feel a little burned by the burdens that they had to negotiate and the barriers they had to negotiate to use clozapine. So we want to make sure they understand that they're not there, but we also want to help them use clozapine appropriately and do those things like dosing slowly and educating patients. We also want to make sure that patients and those supporting them are educated. One of the things we've proposed to the FDA from the stakeholders is, instead of that little educational thing that people get now, that there's a more comprehensive medication guide that talks about what patients and families and caregivers can do to monitor the drug on their own. Things that Dr. Cotes talked about, calling when there's a fever. That's just one example. Or monitoring bowel movement to make sure that somebody doesn't become constipated, or whatever the issue is. We want patients to be able to participate that. And when you put that together with education of prescribers, with making the burden of the REMS disappear, and really finding a way to invest in education of all health professionals about the benefits of clozapine, then I think we can get more prescribers. But it's not going to be easy, and it's going to take a while, and it's going to take resources. And that's why we're trying this kind of all hands on deck approach.
Yeah, Thank you. We just have a couple more minutes. Dr. Kelly, did you want to make a point? I saw that you
No,
unmuted.
I was just going to sort of reiterate that, you know, it is education alone is it's challenging. We have our work cut out for us. In the state of Maryland, we completed a large year-long educational randomized study looking at those who prescribers who received education versus those who didn't. And I should say what we did is we did an educational program of a didactic plus case-based so people could practice, because what we know in the field is that just knowledge doesn't change behavior. And so that's why we attempted to do something a little bit more than just giving knowledge. The attempts to date in New York, other places have not changed behavior with just knowledge. So like, we have to be strategic about like, how do we strategize together to help people get the knowledge they need, but learn to actually start and be motivated to use the medication. And so that's more of a challenge than we think it is. And so we got to all work together on that one.
Yeah, great. Thank you. Yes, Dr. Cortez.
Yeah, I agree with all the points. And I wanted to just talk about this from a systems perspective, and that education is sort of part of it. But like, how as a system do we actually get people to use more clozapine? And one way to think about this is like there's now, tools using technology to, on a population health level, help identify people who might be clozapine candidates. There's so much going on in the clinician-patient dyad interaction. It's difficult, I think, sometimes even for me, who's in the middle of this clozapine, sort of thing, say, okay, this is a clozapine candidate. Like I think if there's ways that systems can help us to identify people, especially earlier on, that might be another way to look at this, and also really thinking about not just education, but incentivization of prescribers to be able to really sort of use more clozapine. What are the levers that really need to change? Because sometimes I feel like when I give a talk on clozapine, people walk out of it like, oh my gosh, I didn't even know there was pneumonia as a potential risk, and all these things. And I don't know. But I think that like systems approaches and incentivization are two main things that need to happen.
Yeah.
Dr. Laitman, 30 seconds.
All right. And, I just wanted to talk about the incentivization also. Rachel Strife has a bill in Arizona basically having the whatchamacallit, the insurance companies pay more for the use of clozapine, because it is, in all reality, more work for the physician, for the healthcare system, but the benefits are enormous. But you really do have to give a carrot.
Great. Thank you so much, everyone. I know we could continue on this panel for hours and hours, but I want to just thank all of the panelists and everyone in the audience today. We've learned a lot about the elimination of the REMS and considerations for next steps from various perspectives. I want to remind everyone that the recording from today's webinar, as well as the summary report with FAQs from questions submitted before and during the webinar, will be available on SNPA's website shortly. And the FDA's plan to eliminate the REMS is really just the beginning. We have a lot further to go to remove the remaining barriers to clozapine treatment and to encourage safe and appropriate use. So thank you again, everybody, for attending, and please watch SNPA's newsletter and communications for additional information in the future. And I hope everyone has a good day.
Thank you.